Good hand washing technique. Could be a surgeon, I don't know yet. Oh, oh, oh. Well, calling for help is the right thing. That's the first thing you want to do in these types of situations.
His jugular vein's been cut. Does anyone have a clean cloth?
How does he know it's the jugular vein? That's pretty impressive.
That's great.
Putting pressure on a wound like this is the first thing you need to do outside of obviously calling for help. Anything you can do to stop the bleeding, put pressure on the site is important in order to help that person survive.
You're killing him.
I'm saving his life. He was bleeding out.
You have it in the wrong place.
I think I remember enough of Anatomy 101 to know where the jugular vein is.
Ooh.
You would be in the right place if he were an adult. He's not an adult. He is a boy, which means you're also putting pressure on his trachea, which means he's not currently breathing.
I can't really see where his hands are, but it's good advice.
There.
Don't take it out.
Some glass.
Don't take it
He'll
out.
be fine.
Yeah.
Who are you?
Hello, I'm Dr. Sean Murphy. I'm a surgical resident at San Jose St. Bonaventure Hospital.
Well, hello, Dr. Sean. Nice to meet you. By the way, just so you know, if you have an object inserted into you, I know that sounds kind of weird. If you get stabbed with a knife, if some glass goes inside of you, if a nail goes inside of you, never pull it out. Make sure you call 911, let the paramedics decide what to do, let them take you to the nearest hospital, because a lot of times what that object is doing is preventing you from bleeding out because it's putting pressure on the spot where the artery or vein was cut.
A special meeting of the board of directors. As much as I love you all, questioning one of my hiring decisions, did you bother to look up the definition of president while you were skimming the dictionary?
You're hiring him to be a surgical resident. My department over my objections.
The bureaucracy that you're seeing here is real. There are board members, there's presidents, there's employees, there's trust funds. So these things exist. They put a lot of pressure on doctors and presidents to make certain decisions.
Yes, he has autism, but he also has savant syndrome. Genius level skills in several areas. He has almost perfect recall. He has spatial intelligence, and he sees things and analyzes things in ways that are just remarkable, in ways that we can't even begin to understand. Those are assets, undeniable assets for any doctor, particularly a surgeon.
I'm not gonna lie, I agree with the president on that. As a surgeon, it's more important to have very good spatial ability, to be able to have perfect recall, to understand the anatomy perfectly, than it probably is to explain the complexity of a specific case and be able to communicate well with people. Most of the time, when you're a surgeon, your patient is not awake. That being said, I think it is still important for surgeons to be able to improve their communication skills, to be able to talk to patients, help them understand the risks and benefits of operations, and make sure that they don't force patients to go into the knife when they don't have to.
You seen her?
No, now go away and turn off the light.
Sure.
Ooh. Resident beef. Resident beef. Oh.
I need you to,
I heard.
And here I thought this was gonna be an all medical show, no Grey's Anatomy drama. At least where I practice medicine, there's different on-call rooms for males and females. There are times where one of the call rooms may be unavailable, and you do have to have a male and a female sleeping in a room together. Usually it's not a problem, but this is unprofessional, folks. It's gonna lead to drama, lots of drama.
We don't have a relationship, we have sex. But
You have a sexual relationship. I wish I had vision like that, that's impressive. Venous distension is caused by increased intrathoracic pressure inside the chest cavity. He's basically saying the veins in the arms are swollen, so he thinks there's some extra pressure going on inside the chest cavity. Can be because of cardiac tamponade, which means that there's blood, usually in a traumatic sense like this, inside the pericardial tissue, which is the lining of the heart, and there could be blood in there and it makes the heart unable to beat properly.
The veins in the boy's left arm are popping.
Is that bad?
I don't see.
Intrathoracic pressure.
No, his chest is rising. He's breathing.
No, the chest is moving paradoxically.
Paradoxical chest movement is a consequence of something known as flail chest. If you get a trauma where a section of your ribs break from the rest of the ribs, that part of the rib cage doesn't move normally when you take a deep breath in and deep breath out. So the chest sort of moves paradoxically. That's what he's talking about. What happens during a pneumothorax, one of the lungs collapses, or sometimes both of the lungs collapse, and you can't oxygenate that area, meaning that when you breathe, no oxygen goes to that area. It causes increased pressure. The life-saving treatment for this is to literally insert a needle in order to release some of that pressure.
Who here has a sharp knife?
Oh!
Blade 5 inches or longer? Nobody?
Is he gonna go into the second or fourth intercostal space?
Can't be back here.
Oh, I need a knife. Where do you keep the knife?
He's going to TSA.
A knife. Sure. Anything else?
I do also need a narrow 6-foot tube and high-proof alcohol and gloves and baggage handling tape, but I'm going to get the alcohol from the duty-free store and the tube from the back of the soda machine.
He's gonna put a chest tube for a traumatic pneumothorax. Looks like he's going to a party with all that Jim Beam. He reminds me of Zac Efron a little bit. I know it's a weird thought to have in the middle of this medical emergency, but I don't know. I always found that blowing to the glove thing really obnoxious. How much bacteria do you have in your mouth? Probably even more than your fingers. You're blowing it inside the glove, but you're getting some of that bacteria on the outside of the glove that you want clean or relatively clean when you're gonna go insert a chest tube into a young boy. He's gonna clean his hands with a Jim Beam, but that's not perfect.
Incision should take place 2 ribs down.
Second intercostal space, my man. He's actually following proper technique because you want to stay in the mid-axillary line, meaning in the middle of your armpit. That way you have a lower probability of hitting the heart when you go in with the scalpel or whatever you're going in with.
Okay, well, why the bottom?
The air will continue to leak and accumulate until the damage can be properly repaired. The tube allows the air to get out. The water in the bottle stops the air from coming back in.
A homemade one-way valve. He's breathing. You saved his life. He saved his life.
Attention pneumothorax, you can literally put a needle in that can release some air, and that equilibrium does enough of a job. You didn't need all of this fancy technology here.
I need to get to San Jose St. Bonaventure Hospital.
That's where we're going.
Good.
One of the classic signs that someone has autism or may have autism is they don't make great eye contact. They're not great at picking up social cues. If you find out that your child has autism, you can start them in these early intervention programs where they teach them how to mimic some of these social cues, where they're not looking to make eye contact with you like we do normally because we have good physical recognition and body language recognition, but they do so because they're trained to do so, to make conversation seem more normal. Early intervention has shown some very promising results for those with autism.
We'll find another school.
No, we won't, because nothing's gonna change. They can't handle him, and I don't blame them, because obviously we can't handle him either. What the hell happened this time? What happened?
You're hurting him.
What did you do?
Those who have autism and grow up with pets actually have better results moving forward in terms of communication, in terms of interpersonability. So if your child does have autism, getting them a pet early on definitely serves a benefit.
It changed. The boy's ECG changed.
It's the same. 86 BPM.
No, it used to be higher.
No, it used to be 86. It's still 86.
It used to come up to here.
That's not the right way to do it. You have to be seated, you have to have calipers, you have to be looking at the strip and comparing the little boxes on the screen. Maybe this guy, he has superhuman powers, it's possible, but in reality, you need to be a lot more careful because this isn't just a game, it's people's lives at risk.
8-year-old healthy boy, status post-encounter with a shattered glass sign, numerous lacerations.
Echo.
Get him set up in trauma 3 with an EKG, full blood work, and a PAN scan.
So far, very accurate. I'm very impressed. The way that the paramedic told the history, very, very accurate.
Adam needs an echocardiogram.
Oh, no, behave yourself, or you'll be removed from the building.
I don't know what to make of this guy. I like him because he's superhuman and knows everything, but it's just so unrealistic, it's crazy. Is this the same security guard who knows everywhere he's gonna go? Maybe this guy's a savant too.
Do an echo.
Sir, the boy's wide open. It's gonna take a while.
Good. That'll give me time to figure out why the hell we're doing an echo. Dr. Brown, you're with me. We're gonna go find your weird guy. Keep him stable.
Surgeons just don't go and look for another doctor or someone else on the street that wanted to give them a recommendation on how to treat this patient.
I noticed that there was a slight reduction in the intensity of the electrocardiogram.
The electrical flow, I noticed that too. The heart rate was the same, but the amplitude dropped.
Pericardial effusion.
Reduced cardiac output,
Would stress other organs.
causing them to shut down.
Yes.
So just to break that down, pericardial effusion, peri means surrounding the heart, the tissue surrounding the heart. Sometimes there's fluid there, and when there's fluid there, that makes it difficult for the heart to beat, and you get cardiac tamponade. That's what I was talking about earlier.
Again. Again. There.
Looks normal to me.
It's not normal.
4 doctors are looking at a scan. They don't believe there to be an issue. This guy comes in, sees an issue with the scan that no one else sees, and now all of a sudden they're starting to believe him that maybe it could be that. If you're looking at the scan, it either is or it isn't. I don't know what they're debating about the concavity that's open to interpretation. I've never seen a situation like this.
The YouTube clip already has over 200,000 views.
That's pretty good, 200,000 views. The more I think about what he did there in the airport, the more I think it's inappropriate. There is a Good Samaritan law that's in place to help with basic emergencies, pulling someone out of a burning car, and in the process you hurt their back, but you were trying to save them. But performing an advanced medical procedure like putting in a chest tube, especially a makeshift chest tube like that, man, unless he saves the boy and it's 100% safe, there's gonna be malpractice and lawyers involved in that case. So the good doctor strikes again.
You saved that boy's life.
Oh, good. His name is Adam. Traumatic pneumothorax. I'm hungry.
Sean, Dr. Melendez's team is going into surgery. I mean, if you're interested.
I mean, how about getting him to sign all the paperwork and disclosures and HIPAA forms and making sure he has identification? Put your mask on. Put your mask on, Sean.
I saw a lot of surgeons in medical school. You're much better than them. I have a lot to learn from you. You're very arrogant.
Matter of fact.
Do you think that helps you be a good surgeon? Does it hurt you as a person? Is it worth it?
And there you have it. First episode of The Good Doctor. Things I definitely enjoyed about the show. Number one, it's fairly medically accurate. The drama in the show is interesting. It kept my attention and I wanted to see more what would happen. I really dig the fact that it gave an inside look into how hard living with autism can be. You know, you can have abusive family, you have bullying that's happening. Dealing with autism is a difficult situation, and I appreciate that the show highlights that. I will say, however, that they almost make him look superhuman, and that's not realistic, so that's definitely a con in my book. But I understand that they need that factor to make the show work.
A month ago, you were in med school being taught by doctors. Today, you are the doctors.
First of all, I've never heard a speech given that dramatically on an intern's first day. Nobody really talks like that. It's much more practical.
5 of you will crack under the pressure. 2 of you will be asked to leave. This is your starting line. This is your arena.
This sounds like Hunger Games more than it does Grey's Anatomy.
No, I'm not gay. It's just that, you know, you were very unforgettable.
O'Malley, Yang, Gray, Steven.
We do get ready together in the mornings. There are locker rooms like this. It's funny to say, but because doctors spend a lot of time in books while in medical school, they're not the greatest at interacting with others or maybe even showing interest in the opposite sex. So I've seen situations like this happen a lot, where someone's trying to make conversation, but they're not great at it, so it comes off very awkward. It's funny, but this is very accurate.
Your first shift starts now and lasts 48 hours. Your interns, grunts, nobodies, bottom of the surgical food chain.
Residents don't work 48-hour calls anymore. They're capped at 80 hours per week. Maybe they go a little bit over that sometimes, but 48 hours is just non-existent. And this started because of the Libby Zion law, which is sadly the name of a young girl who died because residents who were so overworked, they missed catching a diagnosis and she ultimately died.
Run labs, write orders, work every second night until you drop, and don't complain. On-call rooms. Attending call them, sleep when you can, where you...
The on-call rooms look exactly like this. They're very plain, they're very basic. The hospital doesn't budget or allocate any money towards them. You have to change your own sheets. The mattresses are basically plastic, uncomfortable. So this is very accurate.
Dr. Bailey, that's shotgunner.
That means every test in the book, CT, CBC, Chem 7, tox screen.
I love how simply the attending came in and made that decision. He basically saw maybe the chart, maybe a brief explanation of what happened, why the patient came in, and he already has a shotgun approach to this. This is not how medicine works. That's ineffective. You need to have a presumed diagnosis in place so that the labs and tests you order actually confirm a diagnosis. You can't just throw stuff against the wall, shotgun against the wall, whatever he said, and hope something sticks. The only time that is appropriate is if you have no idea why a young, otherwise healthy patient with an unknown history comes in with some sort of weird presentation. Then you can start ordering a broad range of tests. But they knew she had a seizure history, so why are they doing a CT scan? I need more info. More info, please.
Hello? You're so lost. What are you, like, new?
This is where these medical dramas get me. They make it seem like the doctors do everything from A to Z. They diagnose the patient, they run the tests on the patient, they draw the blood, they transport the patient. We have nurses, we have MAs, we have transport staff, we have PT therapists, we have respiratory therapists. I understand that they're trying to build up characters, so they're trying to show as much of them as possible.
I'm just gonna insert my fingers into your rectum.
Why fingers? Just one finger.
Bet you missed a lot when you first started out.
No one was ever that mean. People wanted you to learn, they wanted you to get better. If you go into every procedure or every moment within residency with the concept that you want to learn and you want to do better, people respect that. So I don't necessarily get this hatred that these poor interns are getting. Our cafeterias are bare bones, with usually not the greatest food available. In fact, this is what surprises me most about hospitals. We try and tell people to eat healthy and stay healthy, but the only options to eat are pizza, burgers, chicken fingers, the most unhealthy foods possible. It's crazy to me.
You know what? I'm not the doctor. I'm a doctor, but I'm not Katie's doctor, so I'll go get him for you.
Very common situation to find yourself in, especially on nights when you're covering for the entire hospital and some medical emergency happens. The family wants answers. They have a lot of very important questions that they need answered, but you don't know the patient. You need to put a lot of information together rather quickly and create a thought process that the family can follow along with you so they know what's going on. You don't have to give a direct answer. A lot of residents, young residents especially, think that if they don't have the exact right, truthful answer, they're bad. That's not true. Even seasoned attendings know that there's times to say, we don't know yet what's going on.
Dr. Shepard, he's over there.
Why did I know this McDreamy guy is gonna pop into scene? Oh wait, did they not know each other?
Dr. Shepard, this is inappropriate. Has that ever occurred to you?
I agree with her. In a position of power, you should not be involved in these types of situations. They don't happen that often. As much as we like to believe that there's so much love and drama going on in hospitals, it doesn't happen as much as you think it does. But I have a little She May Come Back for More with the wonderful Dr. Shepard.
Let's move.
Usually we wear eye protection because if blood squirts out into your eye, that's pretty dangerous. So at least have goggles or the face shield that comes attached to the mask.
Appendix is out. Not bad.
That was rather quick. I guess that's for TV's sake. In reality, there's a lot of conversation that occurs between the attending and the intern. Especially with identifying landmarks. They'll often ask you really hard questions, and we call that pimping. And they'll ask you questions that are unrelated to the case, so you prepared for this case, but they'll ask you something else. It's very common.
Bucky, give him a clamp.
BP's dropping. He's choking.
Come on, George.
Today, pull your balls out of your back pocket. Let's go.
Who talks like that? Pull your balls out of your back pocket.
007 is a state of mind.
Well, it says the girl who finished first in her class at Stanford.
We lived with the vending machines. I used to eat Snickers galore when I forgot to bring my healthy alternatives from home.
Mr. Jones has junky veins and he really needs antibiotics. I should start a central line.
So start one. You don't know how.
Clearly I'm very passionate about this. Starting a central line just because you couldn't get a vein with a needle prick is crazy. It's crazy. You're putting the patient at risk.
Dr. Bailey, I don't mean to bother you, but...
Then don't.
It's Mr. Jones.
Is he dying?
No.
Then stop talking to me.
She should have gone to a nurse because nurses have way more experience than even doctors in getting a blood draw.
Next time you wake me, you better be so close to dead.
And that patient doesn't look alive for some reason. Oh, no, he blinked. Okay, he's alive.
Are you sure that's the right diagnosis?
Well, I don't know. I'm only an intern. Here's an idea. Why don't you go spend 4 years in med school and then let me know if it's the right diagnosis?
Ooh, that's what we call a cowboy intern. Basically, a cowboy intern is someone who is so confident in their diagnosis that they start their treatment, they don't explore any other options, they don't have a good differential, meaning other options of what the illness could be. Nurses keep the hospital running. Without them, we would not be able to do our jobs. A lot of times they'll catch our mistakes, they'll be able to identify things we could be doing better. This is the most drama I've ever seen happen in the first 24 hours of being an intern.
The Razapamp's not working.
Phenobarbital, load her with phenobarbital.
Okay, when you say load her with phenobarbital, that's not an order. You need to give the dosage. The nurse needs to say back to you to make sure that she heard the same thing that you said. Otherwise, if the nurse misheard you and you didn't even give the instruction of how much to give, they can give any dose, and that could be lethal to a patient, so that's not real.
Heart stop.
Okay, so heart stopping, that's the code blue. I've talked about this before. Now the patient is dead. If the heart has stopped, the patient is technically dead, and you have to work to revive them to get their heart started back up again. As the resident in charge, you have to instantly give roles to everybody. You do chest compressions, you do this, you give the medications, you monitor the rhythm strip. The most important role being chest compressions. You have to do chest compressions. You cannot stop doing chest compressions. So if you have one person that's giving bad chest compressions because they're tired, you instantly have to swap them out because chest compressions is what extends and saves lives. So right now, them not doing chest compressions is awful. The first thing you do is chest compressions.
Wait. Charge pass.
Whoa. I hope she's not gonna shock the patient. Oh my God, please tell me she's not gonna. No.
Clear.
No, what are you doing, Grey's Anatomy? No.
Still VFib, nothing.
No. Oh, she's in VFib? Then why does it sound like she's flatlining? I've never thrown up in a hospital. I've never seen a doctor throw up in the hospital unless they were sick. Yeah, when things go wrong, you get nauseous. That's part of life. I mean, there's difficult moments that happen. There's times where you're gonna be humbled. I mean, every day I walked into the hospital as a resident, I was humbled. There's a reason why we call it practicing medicine, because we're all practicing, we're all learning, we're all adapting, we're all trying to get better. And the human body is a crazy, crazy thing that we still don't have perfect knowledge of. So I feel for her a little bit, you know, just a little bit. A little dramatic, but I feel for her.
There's our man. It was a seizure disorder. Now you're saying it isn't?
I'm saying that I don't know.
Oh, what do you
Oh, my man McDreamy saying my line. Real doctors are comfortable saying, I don't know. because in reality, there's a lot we don't know. And when cases get very complex, like this young girl who's otherwise healthy is having seizures and then her heart's stopping, it's a very unusual case. Very, very unusual.
I want someone else. A doctor who knows what they're doing. You get me someone else. Someone better than you.
These types of conversations do happen. This is real life. People get very, very upset. It takes a lot of patience to deal with these issues. I've seen doctors get mad and snap. What I do is if I feel like I'm getting angry as well, I step away from the situation, let both parties cool down, and then come back and explain calmly what we're working on. Because if you just say we don't know with no follow-up, it seems like you're not doing anything. But if you say we don't know, but here's what we think it might be and here's what we're working towards, that's a much better answer.
He'll be fine, right?
Tony's gonna sail through. You have nothing to worry about. Promise.
Patients need reassurance. You need to give honest reassurance without over-promising them results.
What are you doing?
I'm suturing a banana with the vain hope that it wakes up my brain.
Suturing bananas, suturing pig's feet is something very common that med students and interns do, so it is true.
She's gonna die if I don't make a diagnosis, which is where you come in. I can't do it alone. I need your extra minds, extra eyes.
This is very dramatic. Every day we have meetings known as rounds where we sit around a table like this, we present a complicated patient, we give the history, we give the physical, we give the test results, and we all brainstorm ideas of what it could be, how we would approach the case, and it's very good practice even if we already know the outcome, but sometimes we don't know the outcome and we are brainstorming like you said here, but it's not this dramatic.
You can't comment, make a face, or react in any way. We had sex.
Bum, bum, bum.
Katie competes in beauty pageants.
I know that, but we have to save her life anyway.
Okay, she has no headaches, no neck pain, her CT is clean. There's no medical proof of an aneurysm.
First of all, this is known as a HIPAA violation. They're basically talking about a patient's case using her name in front of other people who are not involved in her case, and that is strictly against the law. They could get sued for millions of dollars, and rightfully so, because you shouldn't be discussing patient information in elevators. In fact, in most hospitals, you'll see a sign in the elevator that says, please don't discuss patient information.
Wow, that was quick.
His heart had too much damage to get him off bypass. I had to let him go. It happens rarely, but it does happen. The worst part of the game.
Ooh, and he gave that promise to the family saying that he's definitely gonna make it.
Tony's heart had a lot of damage.
You don't do this type of conversation in an open setting like this. You invite the family into a counseling room, you explain what happened, but you don't do it out in the open like this because this is just gonna end badly.
You shouldn't let the fact that we had sex get in the way of you taking your shot.
Shouldn't have had sex, period. Dr. Shepard.
Name the common causes of post-op fever.
The 5 W's, bruh.
Can anybody name the common causes of post-op fever?
Atelectasis, UTI.
Wind, water, wound, walking, wonder drugs.
Yeah, she got the 5 W's.
How would you diagnose?
I hope she says CT scan.
Spiral CT.
And not like
BQ
a VT
scan,
scan or something.
provide O2, dose with heparin, and consult for an IVC filter.
No! She just gave all of the options that you have in testing somebody for a pulmonary embolism, as well as treatments that you may give to someone with a pulmonary embolism.
I'd know you anywhere. You're the spitting image of your mother. Welcome to the game.
Welcome to the game. I've never heard a doctor speak like that. Welcome to the game. You never want to sleep on a stretcher as a resident because it's bad luck. It basically says that you're gonna wind up on a stretcher. You have the on-call rooms, you have couches you could knock out on, so sleeping on a stretcher, that's just bad form.
I should go do this.
You should.
The romance is real.
I'll see you around.
I thought McDreamy would have a little more muscle on him. He kind of is looking a little frail there. This reminds me of where I grew up in Brooklyn. Or is this a jail?
Why are you late?
You're not gonna like the answer.
I already know the answer.
I missed the bus.
I don't doubt it. No bus stops near Brad's.
Every medical show has to start off with some kind of sexual thing. Medicine is so exciting as it is. Why does there have to be sex? Just calm down. Stop having sex for a second.
You should never keep anything from your parents.
And I told mine, cut back. What?
Oh. Are we having a stroke? Slurred speech? Classic sign of a stroke? Oh. Problems with moving the arms?
C.
Call 911.
L-H-E. The. We know that word, the.
I'll call the nurse. Oh no. Oh, that's a seizure. She is having a general tonic-clonic seizure.
29-year-old female. First seizure 1 month ago, lost the ability to speak. Babbled like a baby. Aggressive deterioration of mental status.
See that? They all assume that I'm impatient because of this cane.
So put on a white coat like the rest of us.
I don't want him to think I'm a doctor.
You see where the administration might have a problem with that attitude.
People don't want a sick doctor.
Now wearing your white coat, I guess it's not really a big deal because sometimes I go without my white coat and just wear my stethoscope. It's really for infectious purposes only, so that if you get any kind of germs on you, you don't bring it back home to your family, or if obviously some blood splatters on you or some other bodily fluid, I guess.
Brain tumor. She's gonna die. Boring.
That was a little cold.
She's 29. Whatever she's got is highly unlikely.
The protein markers for the 3 most prevalent brain cancers came up negative.
Tumor markers for brain cancer. That's not how we diagnose brain tumors. We use imaging. That's the gold standard for brain tumors. Obviously, in addition to biopsy if needed, but tumor markers are not a way to rule out a cancer.
And she's not responding to radiation treatment.
None of which is even close to dispositive.
Medically, I'm very confused. There's a patient who had a seizure. They think that she has a tumor. They did some lab work, doesn't show she has a tumor. They're giving her radiation, even though that they don't see a tumor. I cannot be more confused right now, or this totally doesn't make sense medically.
Shouldn't we be speaking to the patient before we start diagnosing?
Is she a doctor?
No, but
everybody lies.
Dr. House doesn't like dealing with patients.
Isn't treating patients why we became doctors?
No, treating illnesses is why we became doctors. Treating patients is what makes most doctors miserable.
So you're trying to eliminate the humanity from the practice of medicine?
If we don't talk to them, they can't lie to us.
Excuse me, Dr. House. You can have a good conversation with patients. You don't need to believe every word they say. You can be honest. You can say you don't know, but give a plan of what you're doing about not knowing. So basically how you're getting to the answer.
First year of medical school, if you hear hoofbeats, you think horses, not zebras.
Very common phrase.
First year of medical school.
Lab in Trenton could have screwed up the blood test. I assume it's a corollary of people lie that people screw up.
Redraw the blood tests and get her scheduled for that contrast MRI ASAP. Let's find out what kind of zebra we're treating here.
So a contrast MRI basically allows you to see what blood vessels are doing within the brain. The fact that they're going to a lab and questioning if the lab is accurate, we do that occasionally, but that's not the first thing we think about. I guess because this case is more complex.
I was expecting you in my office 20 minutes ago.
Really? Well, that's odd, because I had no intention of being in your office 20 minutes ago.
You think we have nothing to talk about?
No, just can't think of anything I'd be interested in.
I sign your paychecks.
I had tenure.
I can still fire you if you're not doing your job.
I'm here from 9 to 5.
Your billings are practically non-existent.
Rough year.
You ignore requests for consults.
I call back. Sometimes I miss the aisle.
You're 6 years behind on your obligations to this clinic.
I was right. This doesn't interest me.
6 years times 3 weeks. You owe me better than 4 months.
It's 5 o'clock. I'm going home.
Doctors don't work 9 to 5s. We have crazy schedules. If someone that's more senior to us, obviously like our boss, like she is in this case, tells you to get something done, you're getting it done. But also because we have a love for the job. We want to treat patients. I don't know why he's being the sarcastic guy, but I will say it's really funny.
I'm angry! You're risking a patient's life.
I assume those are two separate points.
You showed me disrespect. You embarrassed me. And as long as I work here, you have
Is
no
the yelling
legal...
designed to scare me? Because I'm not sure what it is I'm supposed to be scared of. More yelling? That's not scary. That you're gonna hurt me, that's scary, but I'm pretty sure I can outrun you.
Okay, that's cool that he's popping pills on the job. Oh, this is in Jersey, Plainsboro. I work in New Jersey.
All right, Rebecca. I know you may feel a little claustrophobic in there, but we need you to remain still.
It's very true that people get claustrophobic in MRIs. You often have to lay there for an extended period of time. The noise is very loud. So there are times that I have to pre-medicate my patients and give them a dose of a benzodiazepine like Xanax, most commonly, that you're probably familiar with. Yeah, it's really loud. It's even louder than this.
I don't feel so good.
It's all right. Just try to relax.
Oh, is she having another seizure?
Rebecca? Rebecca?
Is she choking? Is she having an anaphylactic attack to the contrast?
Get her out of there.
She probably fell asleep. She's exhausted.
She was claustrophobic 30 seconds ago. She's not sleeping. We gotta get her out of there.
Just be another minute.
She's having an allergic reaction to the gadolinium. She'll be dead in 2 minutes.
Oh, no. Get her out. EpiPen into the upper thigh. Quick.
Oh, she's ashen.
She's not breathing. Epi 0.5.
Come on. I can't ventilate.
Too much edema. Where's the surgical airway pin?
You're gonna need to go in the neck and do a tracheostomy. Did they give her the epi? I didn't see it. Okay, that's way too big of an incision. Okay, not exactly how that goes. If you're allergic to the contrast that they gave for the MRI, it's possible that you can get this anaphylactic attack, which means that your airway starts closing down. Basically, your throat swells up to the point where you can no longer oxygenate. Some people also vomit. Some people get very nauseous. Blood pressure drops. Her airway closed up to the point where she couldn't breathe. But because it's her throat closing up and swelling, if you make an incision in the trachea right here where there's a soft little spot for an opening, you can continue helping the patient breathe. I'm gonna call some inaccuracies here. If a patient turns blue like that, you're hitting a code blue. There's an emergency team coming, nurses, doctors, respiratory therapists. You also gotta get IV set. You gotta figure out why the patient's heart stopped or stopped breathing. There's a lot more that has to happen. You don't just automatically assume it has something to do with the contrast that you gave. And he's still popping pills. What is he popping? Hope those are Advil.
You actually want me to talk to the patient? Get a history? We need to know if there's some genetic or environmental causes triggering an inflammatory response.
I thought everybody lied.
Truth begins in lies. Think about it.
So why did you tell him to not talk to the patient initially, Dr. House? Truth begins in lies just means that in order to find out the truth, you have the person lie to you, and from there you can then start making a deduction on what part they're lying about. So you need to hear the lie. That's why it definitely makes sense to always talk to patients first, regardless if you believe that they're telling the truth or not.
What are you doing?
Painkillers.
Oh, for you, for your leg.
No, because they're yummy. You want one? Make your back feel better.
No, don't do it. That's how the opioid crisis started, House.
Why are you so afraid of making a mistake?
Because I'm a doctor. Because when we make mistakes, people die.
Yes.
Come on. People used to have more respect for cripples, you know. They didn't really.
I can't see.
Uh-oh.
I can't see.
She's having a seizure again.
Hello, in here!
So turning a patient on their side is the smartest move because you want them to, if they're gonna vomit, they don't aspirate.
Can you arrange these to tell a story?
This is a type of neurological testing to see if the person can follow a series of events.
A couple headaches last month, mild fever. Sometimes I can't sleep and I have trouble concentrating.
Apparently not while researching this stuff on the internet.
I was thinking it also might be fibromyalgia.
Excellent diagnosis.
Is there anything for that?
Do you know, I think there just might be. 36 Vicodin and change for $1.
36 Vicodin and change for $1. Oh, placebo. He's gonna give him sugar pills. Oh, and he's stealing the Vicodin for himself. Again, obviously, doctors don't swap out medications. If we prescribe something to the patient, we send an order to pharmacy and the pharmacists fill the order. And we don't replace it with sugar pills for placebo effect.
You said you didn't find anything.
Everything I found was in
You
my...
found ham.
Uh-oh.
So? Where there's ham, there's pork. Where there's pork, there's neurocystic cirrhosis.
That's the condition. Bam, bam, bam. Tapeworm.
See, it fits. It's perfect. It explains everything. But it proves nothing. I can prove it by treating. No, you can't. I was just with her. She doesn't want any more treatments. She doesn't want any more experiments. She wants to go home and die.
That's called the principle of autonomy. Basically, that a patient has the right to refuse treatment at any point as long as they're competent. And by competent, I mean that they're able to understand the consequences of their actions. So if they say they want to go home and you tell them you can possibly die if you go home, they can say that back to you and understand what that means. They're free to go home.
Being an idiot. You have a tapeworm in your brain. It's not pleasant, but if we don't do anything, you'll be dead by the weekend. He's right. We should x-ray her, but we don't x-ray her brain. We x-ray her leg. Worms love thigh muscle. She's got one in her head. I guarantee you there's one in her leg.
I did not know this. This is beyond my expertise and probably most doctors' expertise.
This here is a worm larva.
Wow.
So if it's in my leg, it's in my brain?
Are you looking for a guarantee? It's there. Probably been there 6 to 10 years.
How does he know that?
Albendazole.
He's giving her a dewormer.
If anyone asks, you have 11 daughters and 5 sons.
Wait, that's 16 students. They said her class has 20. Where are the other 5? Why didn't they show up? Oh wait, 11 and 5. Sorry, the other 4. We're happy you're not dead.
I want a hug and a kiss from every single one of you. Get up here right now.
Don't give the kids the worms. I'm just kidding.
Dr. House, you have a patient. He says he needs a refill.
Got change for $1.
That's funny. Patient got hooked on them Tic Tacs.
911, what's your emergency? I think I hear a baby crying in the wall. How's the baby on the wall? No, not on the wall, in the wall. There's a baby inside my wall. I think someone flushed a baby down the toilet.
What?
12 seconds later.
I thought that's just a joke we did as medical students, listening to the wall to hear the other room with the stethoscope. Oh my God. A premature baby that cries loudly enough that you can hear it through a wall and a pipe and it's surviving through water. I mean, like, this is just ridiculous.
All right, it's off. Get the head out, Bobby. Get the head out. You gotta push from below.
This is not how I've delivered babies when I delivered babies. Not from pipes. So much wrong with this.
Okay, pull her out, pull her out, pull her out.
Fakest baby, too.
All right, she's never been starting CPR. Come on.
Correct form with the hands, but gotta push a little deeper, man. This is such a ridiculous scene that I would say this would never happen, but I know one of you is gonna pull out an article where one person in some small rural area this happened to and they survived, and you guys are gonna be like, see, Mike, you don't know what you're talking about as a doctor.
Mike, stop.
Your daughter just had a baby. We have to get her to the hospital.
Yo, is that the mother? No, screw her.
She's bleeding out. She's a child.
That's ridiculous. You don't get to play judge and jury. You gotta save everyone's life, especially when it comes to a child who's lost a lot of blood. Who knows if she's in her right state of mind?
Yo, if this baby dies, it's on you.
Why would the baby die and why is it on her? What does she have to do with anything?
Who is choking you? Do you know him?
Oh, that's a boa. Snake fans, help me out here. That's a problem. Yes, call for help.
Bobby, it's no use. That thing is like 10 feet long. Its constriction strength is like 50 pounds per square inch.
Everyone is Dr. House.
Crap, it's getting really tight. I think we're gonna have to put it down. Okay, stand back.
Spartacus.
Yeah, well, it was him or you, and faced with a situation like that, I always choose to save the more attractive one.
Hope he gets fired after a statement like that.
Would you ever speak to a patient that way?
I would not. Respectfully.
What's your emergency? Shark! Shark! A man's been attacked by a shark.
Oh, man.
Beach are you on, ma'am? We're not on the beach. We're on the freeway.
What? This show is so incredible.
What the hell?
Tiger shark. We were transporting her for release into the wild. Truck jackknifed.
The truck jackknifed, and how did the guy's arm end up inside the shark? Someone needs to explain that to me.
Can we wait that long or just,
No, don't kill her! She's come so far!
Award for empathy goes to that gentleman. He's getting his arm literally torn off, and he's like, think about the shark.
All right, let's get him transported now. Nice and easy.
From a brachial artery laceration, you can die in seconds.
How deep is it?
Yeah, his full arm.
It's the whole thing is inside.
And behold, the Salabasana.
Everything hurts. The baby, is he okay?
Check your baby right now, okay? I'm gonna touch you right here in your stomach. Okay, there's no trauma to the abdomen.
Why would there be trauma to the abdomen? She's doing yoga.
Easy. I'm gonna take you.
All right, I'm gonna take care of that. You take care of this.
Here we go, I got you.
I think I'm having contractions.
Are they real contractions, though?
All right, what's your name?
Beth,
Okay, I need a cup of water for Beth.
am I in labor?
I think it's Braxton Hicks.
I mean, Braxton Hicks contractions are something reasonable to think about. How he knew that instantly without understanding if she's totally in labor or not, I have no idea. That's kind of ridiculous.
You get you nice and relaxed and hydrate, okay?
There's just like really good questions to be asked here, not are you thirsty?
Oh my God, my water broke.
What is this class?
911, what's your emergency?
My son, he hit his head on the diving board and he's not breathing. Oh my God, he's turning blue.
I need you to perform CPR on him.
Interesting that they'd say to perform CPR right away. I would like to check for a pulse first, but if he's turning blue, that probably means he's not breathing, he's pulseless, he's non-responsive. Again, chest compressions, chest compressions, chest compressions. It's not about mouth to mouth anymore. It's about pumping the heart and causing it to push the blood throughout your system, which still has some oxygen in it.
Water out. Coming around, starting compressions.
I mean, I would have loved to see them check for a pulse here.
He's underwater?
I don't know, a few minutes maybe.
Those are terrible chest compressions. They have to be at least 2 inches deep. You have to risk breaking ribs in order for them to be effective. Remember, the job of the chest compressions is to actually compress the heart. And if you're just doing them superficially, you're just doing it for a show. They are doing it for a show. I guess that's okay.
As soon as help arrives, most people just hang up.
Yeah. What are you, sad?
Okay, just hang on.
That's a no-no. Never point anything with gun at yourself. Nail gun, paintball gun, cap gun. Guns. He needs a level 1 trauma surgeon stat.
I don't know what I'm supposed to do.
Don't pull it out.
No, do not remove the nail. Help is on the way.
I'm gonna clear your shirt so we can see what we're working with.
Dude, do not clear anything. Put him on the stretcher and bring him to the hospital where emergency surgery can happen.
You hit the bullseye.
Who makes jokes like that? Hit the bullseye.
Nice and easy. Bring it around.
Sure.
Careful.
If he hit a lung, he's also gonna have a collapsed lung there as well.
Take a few deep breaths for me.
Bro, just put him on the stretcher, bring him to the hospital. Stop torturing the man.
I need to get you to the hospital for pericardiocentesis. That's where they'll drain the fluid.
Dude, you don't even know what is the extent of the damage. This is ridiculous that they're diagnosing him already knowing everything that's happening. Do you know why I'm getting so angry? Because too often patients come in and someone does this like incorrect diagnosis thing on the go, and then I have to come in and correct all this misinformation, and it confuses patients. It's hard enough to hear what's happening here when you have a nail gun in your heart, but then imagine trying to deal with who's right, who's wrong.
Of course I did. Why?
That is not a good rhythm. Yep, that's a problem. That is a problem.
Fix it at the hospital, but only if he's not dead.
In this case, there's nothing you can do. The only thing you can do is try and resuscitate. But like pulling the nail out, pushing the nail further in, you're only gonna do more damage.
Come on, you're not leaving your daughter hanging like that.
We got a pulse.
Yep. Heart's beating again.
Yeah, heart's beating again, but he's actively bleeding out. There's like zero use for celebrating here. It's quite often that a patient gets resuscitated with CPR only to lose their pulse shortly thereafter. So like this is not a win by any means.
Can't move my neck.
Oh no. Is that a Phineas Gage situation right now?
Got a piece of rebar through his skull. How is that even possible?
Well, it's possible. Brain tissue has no nociceptors. It can't feel pain.
That is actually true. However, the meninges feel pain, skin feels pain, and you know all those videos circulating around with the person playing an instrument while they're doing brain surgery? That can happen because the brain has no pain receptors.
Why aren't you guys like cutting me out of here?
It's complicated.
Why?
You've been injured, Jim.
Well, how bad is it?
It's not good.
What is this conversation thing that happens? This is not real. Just do your job. You're 911. Don't start taking selfies and FaceTiming your friends.
911, what's your emergency? I'm at Metro Fitness on Hollywood. My boss is burning up. You mean he's feverish? No, that's
Burning
not
up?
what I mean. I smelled something burning.
Oh my God.
We all kept trying to tell him to get it fixed.
She couldn't have unplugged it?
How the hell didn't he just get out?
Might have had a stroke.
How did he know he has a stroke? I mean, these guys with their like house MD ridiculous diagnoses.
Me too, may have had a stroke. Drugs could be an underlying cause. What was he on?
What is this guy? He's on drugs. How do you know? Look at him. What do you mean, look at him?
Starting compressions.
Good compressions. Yeah, that's normal, so keep going. I mean, not normal, but normal if your skin's so damaged, but the chest compressions override that, because remember, when someone's heart stops, that means they're dead. So whether or not you damage their skin, they're already dead. Try and bring them back.
Nope, he's gone.
What do you mean, nope, he's gone? Do more chest compressions, try and bring him back. My hands got dirty, he's gone. I'm getting mad at the show.
We have a stunt so daring, a video so bold, it might just break the internet!
Oh my God, is this a YouTube challenge, a TikTok challenge?
This!
What is the purpose of this? How is the bike not moving? How long has that poor guy been on there? He's probably like completely out of it.
Hey, can you hear me?
Oh, that's a problem. Need an ophthalmology consult stat.
Could be G-lock.
G-force poisoning from the force of the spin?
Right now, all his blood is pooling inside his head. It's pressing against his brain, which is why he's out cold.
I don't know if that's G-lock. G-lock is when you essentially have your blood go to the lower part of your body and you're not getting enough circulation. And this is a very big problem for F-16 pilots. I actually flew an F-16, so I studied this. Click the video down below.
In you go.
I would not do this without an ophthalmologist on site. I would not do this. Like, there's no way firefighters or first responders would do this. Wow, that was super.
Eventually, could you die from spinning that much?
I mean, you could die from anything. Like, can you run to your death? Yeah.
Doesn't look too bad, all right? You're gonna be all right.
Good triage.
45-year-old male, left leg amputation.
Treatment 2, Trey Motorman, GCS3, BP of 90 by PAL.
GCS3 is the Glasgow Coma Scale. 3 is very bad. You need to be intubated. You're basically in a life or death situation at that moment.
He keeps biting down. I can't get the blade in. Look, you bag him. I'll do CPR.
If you can't insert a tube to help someone breathe, one thing you can do is you can continue bagging them. That still oxygenates their airway. It's obviously not as ideal as putting an endotracheal tube in, but the most important thing is CPR, chest compressions, chest compressions, chest compressions.
Almost there, it's not time yet.
Never ideal to do chest compressions with one arm like that, but I can understand if he's been doing chest compressions for 15 minutes. It's really tough. It's tiring to do chest compressions. I've done chest compressions for a while, and generally after each round, you have a student or a resident standing behind you ready to jump in and start doing the chest compressions. Because it's all about at least getting 2 inches of compression to the chest, which can sometimes break ribs, but it's all about getting them enough time to get to the hospital to hopefully save their life.
I got it from here, man.
Nope, he's mine.
Okay, who the hell is this guy?
Says he's a doc.
Get off the gurney, Doc. I'm senior resident in this ER.
Yeah, well, I'm your new trauma fellow.
Doesn't happen like that. Trauma fellows don't just run in. This guy could be anybody. You need to see some ID. I'm all for the show, trying to set up the stage for this character, but people don't just run into the hospital and say, I'm the doctor now.
Get a BP and keep giving him blood. Send a rainbow of tubes and a type and cross. Get his blood gas and get him to the OR.
Type and cross, again, you're trying to find out the correct blood type. For now, giving O negative is fine, but you don't want to keep wasting the O negative blood, so you want to do a type and cross. When he says the rainbow of tubes, that's basically tubes that are sent off for a wide array of tests like CBC, which is a complete blood count, BMP or CMP, which is a metabolic panel, a PT-INR, which shows clotting abilities and clotting times.
No gag reflex, didn't even need sedation. Not good.
We got another problem. This woman's pregnant.
What he's doing there with the ultrasound is called a fast scan. It basically allows you to see if there's any internal bleeding going on, especially in the abdomen, because you can lose a lot of blood in the abdomen without even knowing that you're bleeding into the abdomen. But obviously in this situation, he's found that this patient is pregnant, which complicates the situation even more.
20-year-old male, cystic fibrosis, complaining of chills, labored breathing, temps 98.
Jamie, I do.
Hi, Maggie.
Back so soon?
I missed you guys.
Cystic fibrosis is it's a deadly illness, unfortunately, and it basically, you build up so much mucus in your airway because you cannot clear the mucus out of your airway as efficiently as someone who's healthy and doesn't have cystic fibrosis. So you get very often lung infections, obstruction in your airway, and most people live somewhere into their 40s or 50s with the illness, and that's pretty much the life expectancy with someone who has cystic fibrosis.
Now, Mr. Dilson, I see that you're using inhaled antibiotics, tobramycin, albuterol. You wear a vibration jacket at night and use a humidifier?
The vibration jacket actually helps break up some of that mucus and allows it to naturally come out when a patient coughs. Very commonly, we use something known as chest physical therapy, which is almost like clapping on the chest to help clear some of the mucus. Parents of young children who have cystic fibrosis are trained in giving their children this procedure.
Baby checks out fine. Healthy heartbeat, amniotic sac, and placenta are intact. Gina, though, I'm afraid, suffered a traumatic head injury, and so far she's unresponsive. We need to contact her family if you have any information.
My husband and I are pretty much her family. She's been living with us since before the embryo was implanted.
That's such a difficult situation. I mean, to have someone be a surrogate to carry your baby, and then they're living with you and they're involved in this horrible accident and they have a traumatic brain injury where they're being kept alive by machines. That's gonna be a tough decision whether or not to keep her alive using machines so that the baby can continue growing and get to at least to a stage where the baby can survive on its own following a C-section. Man.
Jamie, I've got your test results back. I wish they were a little more encouraging. You're pancytopenic, which means that your cell counts are low. You've got a blood pH of 7.14.
When your blood pH is that low, that means you're trapping carbon dioxide within your body, and you're having obstruction, which comes from the cystic fibrosis. That's very dangerous because when you go into an acidotic state like that, your enzymes within your body can't function and you can die.
I'd like to intubate you, put you to sleep, get you on a ventilator. You're getting fatigued. This would just allow you to rest so that the antibiotics can do their job.
I've been intubated 8 times. I think I'll skip it.
The purpose of intubating someone who has such a strong acidosis is when you put the tube in, it allows the person to not work to breathe so heavy to expel all that carbon dioxide. The machine basically does it for them. And again, it allows them to rest, it allows the antibiotics to do their job, and it improves the pH quicker than the person can do themselves. Very uncomfortable, not a lot of patients like it. I've never seen, and again, I'm not a trauma surgeon, I'm not an ER doctor, but I haven't seen options given that frankly to patients. If a pH was that low in my hospital, generally we would strongly advise the patient to intubate them. But again, I'm not a super specialized in this field, so I'm just going off based off my own experiences.
Sherry?
Dr. Halstead?
Need to blow down her CO2, take her off the vent and bag her, give her a dose of Manadol, and increase her dopamine drip to 12.
Right away. Doctor?
Gina's intracranial pressure is rising.
What happens after an injury to the brain is just like any part of the body, there exists inflammation, swelling, edema, and the problem with having swelling inside the cranium is that the cranium is a skull. It's meant to keep things from coming in and protect you, but it also crams the brain when there's edema and swelling, and it actually damages the brain further and can be fatal. So you try and control it with medications. You try and give the patient something to reduce the swelling in the brain. There's also some physical things you can do, like elevating the head to hopefully get some of the fluid to come down. But in reality, if the condition gets worse, you need to do the surgery to open a piece of the cranium to allow the brain to swell and not cause increased pressure within the brain.
Intubating Jamie is the only hope we have of keeping him alive.
What's that gonna give him? A week? 10 days?
It could be 6 months, a year, more.
This goes to the heart of the issue of patient autonomy, that they have the right to choose what happens to their body. I don't know how old Jamie is. Once you're at the age of 18 or older, you have the right to turn down medical treatments. You have the right and say that as long as you understand the consequences of what you're doing, you can undergo or skip any treatment that you want. Nobody can force treatments upon you. I understand what the ER doctor is doing. I also understand what the psychiatrist is doing.
As soon as we hear something, I'll let you know. Rachel? Rachel, can you hear me?
What is wrong? What's happening?
I can't find a pulse.
Oh my God.
Well, the medical student is doing the exact right thing. Call the alert, start doing chest compressions right away.
You're not compressing the heart, Sarah. You gotta go harder.
But she's so small, I don't want to...
Harder, do it, let's go. Come on, Sarah, harder. Hold. There we go, back inside his Getty BP.
What happened?
She rested, we got her back.
I can't get an IV. Hand me a drill, get an IO line.
An IO line is an interosseous line. In children, sometimes it's difficult to put an IV line. Sometimes they need extra fluids. What we can do is we can drill a little needle right, it sounds brutal, but it's really not that bad. Drill a little needle directly into the shin bone. And what that allows us to do is to give extra fluids and medications to that area.
I just broke a little girl's ribs.
Reese, you saved the girl's life.
Breaking someone's ribs while doing proper CPR is part of the course, and the CPR actually saved lives. The ribs are an unintended consequence, but they're a side effect of trying to keep the young girl alive.
This is Jorge's. ¿Entiendes?
Yes.
Inside, I found this.
Why would you give that to her in this moment? That's so unnecessary. I promise this will not happen in the hospital.
What happened with the little girl?
She had a cardiac contusion. Bruising caused her to arrest. She's good now, but it was a real scare.
Sometimes when you have a direct injury to the heart, that can cause a contusion, which is just a bruise. And sometimes that can mess with the electrical activity of your heart and cause you to have a cardiac arrest, which means that it just stops the cardiac rhythm. Actually, this is a common scenario during baseball games. If someone hits a line drive and it hits someone in the infield directly on the chest, if it hits in a specific time of the electrical rhythm, you can actually stop the heart.
Jorge's brain was without oxygen for too long. Pasó mucho tiempo sin oxígeno.
We have translators in the hospital for moments like this. If you're gonna have a conversation that's about life or death, you need a translator there. Your broken Spanish isn't the right way to communicate with the patient.
He's 20 years old. Without new lungs, he will die.
Tiene 20 años. Sin pulmones nuevos, morirá.
Your fiancé.
Tu prometido.
The man you loved.
El hombre que amabas.
The man who loved you.
El hombre que te amaba.
I can't save his life.
A little unethical here. They're talking about the patient's condition to a non-family member. It's technically breaking information protocol, but I don't think they're gonna get in trouble for this. I think they're doing the right thing. And that's why a lot of rules are open to interpretation. And I think here they're looking out for the best interest of the patient and maybe telling his patient information to somebody else, but in hopes to save his life. So I think legally this isn't right, but I think morally and ethically it's the right move.
Going back to the hospital?
Yeah. Wouldn't mind being there when he wakes up.
Can I come?
Sure.
I appreciate that the doctors want to spend their off time with the patient, but you gotta recharge your own batteries. You gotta get the 7 to 9 hours of sleep so you can make the best decisions for your patients the following day. Again, you wanna be empathetic, but you don't wanna burn out either because then your future patients will suffer also. So it's a fine line between being a good empathetic doctor and burning yourself out. This show is supposed to be a comedy, but I've also heard that it's rated one of the most medically accurate shows out there. Let's find out. Lie number 1, doctors don't wake up at 6 a.m. We wake up at 4 a.m. or 5 a.m. at the latest because usually we have patients scheduled for 6 a.m. or if we're gonna be on a hospital shift, you need to come in for rounding and pre-rounding. I don't know what kind of doctor this guy is, but 6 a.m. is a bit late.
And 4 years of pre-med, 4 years of med school, and tons of unpaid loans have made me realize one thing.
Good. Could you go drop an NG tube on the patient in 234 and call the attending if the lavage is positive?
I don't know jack.
Your first day in the hospital is a scary day. And I'm not talking about when you're a medical student on your clinical rotations because no one really expects much from you when you're a medical student. When you go in as a resident, you're a doctor. You have a medical degree, so people have expectations that you'll know what you're doing. Now, just because you have the knowledge from a textbook on how to accomplish something, it doesn't mean that you have first-hand experience, and hands-on experience really matters, especially when dealing with other people. Because medicine is about dealing with people, not disease.
The hospital doesn't want to be sued. Being sued is not a good thing. Finally, doctors, if there is a mistake, don't admit it to the patient.
Here's a fun fact about this. Common sense-wise, you may think that, yes, if you hide the fact that you made a mistake, you're less likely to get sued. But what research has actually shown is that if you're honest and come clean about your mistake, which doctors totally make mistakes, we're not robots. If you come clean about your mistakes and show the proactive steps you've taken to prevent that mistake from occurring again, patients are less likely to sue you. Patients' families are less likely to sue you. So it's about owning up, it's about being a good person, and if you're a human first, you're less likely to get sued.
I'm a tool. I'm a tool. I'm a tool, an unbelievably annoying tool. Yeah, finally. These are your beepers. From now on, they control your entire life.
You would actually think that because it's 2018, or at least when I was doing residency, it was 2017, you wouldn't have beepers anymore. Guess what? We still have those same pagers. It's crazy. I actually had the communications people from the hospital send a message to my phone instead of to the pager, and I actually had them change that. To me, it just felt way too old school to be walking around with one of those pagers on me.
You've done this to cadavers before, so this guy's alive. Just poke it through his skin. Poke it through, now!
Time's up. Carla, would you do it for him, please? I'm also gonna need an ABG.
Why are you telling her?
Shut up and watch.
Okay, this is actually really funny. Very true that when you go in your first day, some of the senior doctors will want to see your ability to do some of the procedures like put an IV in, to do an ABG, which is an arterial blood gas. It's basically when you go into the artery, usually the radial artery, which is at the end of your wrist. It's one of the harder sticks because you can see veins. The artery, you actually have to feel the pulse and then insert the needle based on where you're feeling the pulse.
Dr. Dorian, can you tell me what ailment most often
I think I'm gonna love rounds. It's like being on a game show.
What is uremia? That's my boy.
This is a cool example of what rounds are. You basically have a list of patients that your team is responsible for, and you go around with your entire team, with the attending being in charge. Sometimes it's the chief of medicine. And you walk around to each patient's bedside, and you discuss the case, not only with the patient, but with the team as well. Sometimes you get the doctor asking you questions. That's a form of pimping. They're trying to get you to think outside the box. The way that I like to lead rounds is sometimes we know already what the patient has because it's written on our reports, but I would say, well, what if this test came back negative? Or what if Mr. Johnson presented without the headaches? What would change in your diagnoses? And that way it can facilitate how a person thinks, because the quality of a good doctor is being able to adapt, is to be able to think on the spot. Back in the day, they were very mean about this pimping process, and if you didn't get it right, they would talk down to you, they would call you stupid. I don't see that negativity there anymore, and I think the whole process has become a lot more positive reinforcement based.
I'm going for it.
Infection?
That's my girl. Moving on.
I knew the answer.
I'm sure you did.
I was just frazzled.
How could you not?
You know, it's
Oh, I know, yeah.
good. But thanks. If there's anything I can ever do for you, just.
You could let me take you to dinner tomorrow night.
We're back to the sex. Even a comedy medical show that is funny on its own still needs to have a little sex thrown in there.
What the hell are you doing?
All those newspapers are very legitimate. Like having a ton of newspapers just sprawled about that are very old, having that horrible TV that's like sitting way too high up so you have to jack your neck up. You daydream a lot, especially when you've been up for 24 hours. So that part of this is very realistic.
Did you actually just page me to find out how much Tylenol to give to Mrs. Lenzner?
I was worried that it could exacerbate the patient's...
It's regular strength Tylenol. Here's what you do. Get her to open her mouth, take a handful, and throw it at her. Whatever sticks, that's the correct dosage.
I'm gonna be honest and say that I've done stuff like this. My first rotation going into residency was on the surgical unit, and I texted my senior residents or attendings for everything. And then after a few weeks, I realized, like, why am I doing this? If I know it's the answer and I've double checked that it's the answer, why am I asking for permission when I have a doctorate degree? So it takes some time to build up confidence. Not every person works at the same pace. So I totally get where he's coming from asking about the Tylenol.
For the love of God, what?
Do we think we should be talking about this info?
Her? She's dead.
Oh my God. All right, this show's crazy.
If they find out the nurses are doing your procedures for you, your ass will be kicked out of here so quick it'll make your head spin.
Nurses do the majority of the procedures as it is now. If the procedure is too difficult, you're the one that's responsible to come in and solve that problem. If then you can't do it, then you can escalate to either another resident or maybe the attending physician. But generally, nurses are better at doing the procedures than us because they do them so much more often, so their hands are much more well-equipped to do the procedures.
Not really dead.
This is such a wicked show. Let's go.
And like that, I was back in high school. You see, surgical interns, they're all slice them and dice them. They're the jocks. Medical interns, we're trained to think about the body, diagnose, test. The medical interns, well...
You got a stain.
We're the chess club.
Not exactly accurate, but has some truth behind it. Surgical interns and residents are much more practical. They see a problem, they want to fix it, they want to go in and cut, reassemble, suture. Whereas as a medical intern or resident, you have to really think about, is this patient going to follow the treatment? Is this medicine going to interact with all these other medications? Sometimes surgery will consult us as the medical team to come in and manage something that's very simple for us, but to them, it's something that they don't do often. Whereas on the other hand, we'll call for their help on simple surgical procedures, even like sutures if they get too complicated for us. It's really about teamwork and making it a balanced approach.
My first code. See, here's how it works. Someone's heart fails, they beep everyone. The first doctor in has to run the room, tell everyone what to do, basically decide if the patient lives or dies. What, am I crazy?
In general, you have a code team that's set to respond to these code blues. Yes, it's about who gets there first, but it's not about any doctor in the hospital should just run up and start treating the patient. We have teams dedicated for this. Because imagine if everyone's busy and no one responds, what, the person just ends up dying? Not the case. There's strict responsibilities here. In my hospital, the way it worked was the ICU on-call teams usually ran the code, and if there was something else going on, then the medical team came in and ran the code. Not gonna lie, it was scary when you would have one code and then another code happen simultaneously, and then maybe a rapid response, meaning that someone's heart didn't stop, but something serious is happening where their heart may stop soon. And at the same time, you get an admission. It can get really hectic.
Hey, champ. First night on call starts soon, huh? Gosh, you must be excited.
You betcha.
The first night I was on call, I was terrified because you have one senior attending, and if they get busy with something, it's all on you, and you're so worried about making the wrong decision. But if you double check everything that you do, speak to people who have more experience than you when you aren't sure about what to do, you're gonna be fine. While those nerves are totally normal and expected, there are ways to combat it. By being informed, by being knowledgeable, and by being smart. I can relate to the feeling of like coming on call and instantly getting things to do. For me, my call started at 7 p.m. So when I would go in at 7 p.m., the team that's coming off would hand off to the pager to me and say, hey, we were so behind that there's still 3 or 4 admissions that are in the emergency room that need to be done and brought into the hospital. So you come in and you already have stuff to do. And then on top of that, you're getting pages about new things that are going on.
The attending thinks it was a pulmonary embolism. No way anyone could have caught it. Anyhow, you have to pronounce him.
Why didn't anybody page me?
Could you just pronounce him so I can go home?
Okay, so this is an interesting thing. Pronouncing someone dead is usually done by the on-call resident, so that's accurate. What happens is if a person dies in the hospital, the nurse pages the on-call resident, they have to do a full exam. We look at the pupillary response, pain threshold. We put a pen on the nail bed and we press very heavily. So if the patient is somehow not dead, they would wake up. We listen to the heart, we listen to the lungs for extended period of time. There's like this whole physical exam that we do. And then we write a long note calling the time of death, suspected cause of death. In addition to that, once you pronounce the patient, you have to talk to the family, which is a very difficult conversation. You mature very quickly during these moments.
Even now, when I finally get to go home, in the back of my head, I'll know the hospital's still here, wide awake.
That line is very true. There's been times like I was in a good mood to go home and I was like, let me just stroll through the ER, and something happened and I needed to help someone out, and I end up staying 3, 4, 5 hours past my shift. It's like one of those things, go home while you still can, because you need to be back here the next night to save lives.
The most important thing is that I got through my first 3 days without looking like a complete idiot.
Another episode of the Dr. React series is in the books. Mixed feelings on this one, and that's surprising because I thought I would find it really funny. There was definitely parts that had me laughing and I was like, yeah, that's so true. But I don't know, some parts are just so dark and mean-spirited that I couldn't get behind it. It pushes a lot of the stereotypes on the medical community that aren't good to be pushed, and we should be getting rid of them instead of celebrating them. I probably need to watch more episodes to truly understand what the characters are all about. It is true surgeons play their favorite music
yank that sucker.
when they're operating.
Did you guys know this is my first surgery with Dr. Bell?
No kidding. We have to get a photo. Make it quick.
Get in, Chew.
Okay, no one's taking out their cell phone in the middle of an operation and taking selfies.
I wish we could do one without the mask.
Quickly.
Uh-oh. Tremor?
Just one more. Think we got it. I'm going to send this to my mother.
You'll get us off fire. Cameras on around the door.
I was waking up. I need up the seal.
Oh my God. You hit an artery? On an appendectomy?
You're losing blood fast. I need 2 liters of normal saline wide open. Call for 4 units of blood and 2 FFP stat. And give him Richard Dellenberg.
Tracking instruction.
He's breathing very heavily, rightfully so.
I have something. He's lost at least 2 liters already.
Come on.
What splattered on him, maybe a 1/4 of a liter. 2 liters is a lot of blood, and that's probably not 2 liters. He has some shaky hands, may have hit an artery. When you hit an artery, it does splash like that. The first step during a surgery is to get one of the tools called the hemostat, and basically it clamps off the artery to get it to stop bleeding.
CPRs are going to put all that blood back into his body.
Whoa.
Die on me.
Epi? I'm assuming this is someone's bad dream because they're not following proper protocol. I have no idea why he's stopping CPR. Nothing makes sense here.
We're so dead.
Time of death.
Okay. Whoa. You guys told me The Resident is the most accurate medical show on television. So far, this has been incredibly inaccurate. This gentleman's heart stopped in the middle of the procedure because he was losing blood. They were supposed to get blood and start the blood flow through an IV. They started chest compressions. They didn't follow the cardiac life support algorithm of giving epinephrine, rechecking the rhythm after 2 minutes. And it looks like they called a time of death after 30 seconds.
Well, I think we can all agree it was the misdosed Zevo.
What?
Led this unfortunate situation.
You're kidding, right?
The patient woke up, his arm hit my hand.
You left the blade in the field. You nicked the artery.
Well, you never
walked
should have
through
okayed
it.
him for surgery in the first place. His INR was abnormal.
The upper range of normal. That's never gonna
You know
fly.
what?
We're all on the same team here, right?
Oh my God. He's trying to blame it on the patient coming in with a high INR, which is basically the inability of a patient to clot properly. So if you have a very high INR, you're more likely to bleed out. If this happened, I hope that the people around me have the courage to speak up and say something about it. In fact, one of the biggest initiatives that have been going on in hospitals over the last 10 to 20 years is to give nurses the voice and the courage to speak up when they see doctors, especially senior doctors like this gentleman who's a chief of surgery who's been practicing for 30 years, to speak up and say, no, you've made a mistake and we need to own up to it and figure out what went wrong and how we can prevent this in the future. This is awful. This is an awful situation. I have goosebumps, honestly.
We have 206 bones and I can name each one.
It's a very cheesy way to turn somebody on.
Everything you thought you knew about medicine is wrong. All the rules you followed will break. I have only one rule, covers everything. I'm never wrong. You do whatever the hell I tell you, no questions asked.
I can't take this guy seriously. He sounds like he's from a Western movie, and he's like, welcome to the wild, wild West. Yes, in reality, medical school is quite different from life as a resident. There's a lot that you think you know about working in a hospital when in reality you start working in a residency, you realize that you didn't know or what you thought you knew was actually wrong and you practice it in a different way. That's why those who get overly confident by regurgitating facts and figures really have their minds blown when they enter the hospital and they see the way medicine is practiced, because humans are very complex. They don't present like the way the textbook says they will present. They don't always give you a clear indication of what's wrong with them. It's a lot more of a puzzle and figuring out what's going on. The heart of what he's saying is true. The way he's presenting it is way overblown and dramatic.
My last resident had an attitude too, and you know where he is now? He's teaching 8th grade biology. I cut him. You know what that means? It means I can end your career just like that. Remove you from this residency at any time for any reason, and if I do that, no other residency will take you.
Completely untrue. Senior residents don't have the ability to get you kicked out unless you do something just horribly wrong. And if you lose your spot in a residency because you disagree with a senior resident, it doesn't mean that no other residencies will touch you. Again, a completely overblown statement and untrue, I guess, for the dramatic factor of the show.
This is Dobroslav. He's Croatian, speaks no English. He has severe cauda equina syndrome. What are we worried about?
Early paralysis.
Hey, man, what's the first sign of paralysis?
Anal tone.
Stick your finger up his ass.
Normal procedure is to get an MRI.
Thank you so much for telling me about normal procedure.
Cauda equina syndrome is where you have severe narrowing of the area of the spinal cord where your nerves travel through. So you lose a sensation of your lower limbs. You lose the ability to have proper anal tone. Some people have incontinence where they just pass their bowels, they lose urinary control and just have urinary incontinence, meaning that they pee themselves. And if any of those things happen, you have to call 911 because cauda equina, this procedure, this condition that they're talking about, is a medical emergency. Obviously, one of the ways to test that is to do a rectal exam and check the sphincter tone, but he's being really rude about it.
Good afternoon. We need to explore your rectum.
Dobar dan. Moramo
Back in the day, we used to have translators that lived in the hospital, worked in the hospital. Now we have really good intercom systems. Some hospitals even have iPads that connect you to another person who can be the functioning translator. The correct way to do this is to not talk to the translator and have them translate it, but talk to the patient normally and have the translator somewhere behind you or on the phone talking to them, translating. So you're still having a conversation with the patient, not a conversation with the translator. That's a very important distinction to make. I was hoping this show wouldn't involve sex, but I'm striking out week by week because apparently everyone's in love in the hospital. Maybe I've just worked in the wrong hospitals.
Acute leukemic on chemo. Fiance caught because she was shaking uncontrollably. She spiked the fever this morning, 100.8. Also, there's...
So commonly, someone who has chemotherapy performed on them, they can develop something known as neutropenic fever. It's when a specific type of white blood cell is very low and you have a fever. It's a very dangerous situation. Broad spectrum antibiotics, meaning antibiotics that cover a whole host of different bacteria, need to be given right away in order to prevent the person from dying because their immune system isn't capable in dealing with the bacteria on its own. So I think this is a pretty interesting case already, and I've just seen like 5 seconds of it.
There was some vomiting. There's no blood in it. Last chemo was a week ago. Hey.
You're here.
Very accurate presentation so far. Knowing when the last chemo treatment's very important when judging what the next step of the treatment plan is.
I'm scared.
You're running a fever. It's just another infection. Chemo's still crushing your immune system. I'll get you started on broad-spectrum antibiotics again. Acetaminophen to get your fever down. Feed cultures from both arms. Urine, she'll need a head CT.
Okay.
Don't worry. We'll get this under control, get you both back home soon.
Having a good rapport with patients like that is very important. Nurses and some doctors and even people that are just spending time in the hospital for a short period of time are very somber when they're around sick people, especially chronically sick people who've been sick for a long period of time. But in reality, they would love for someone to come in with a little more lighthearted approach, can laugh with them, make them smile. I'll always try and have a laugh with them, tell some jokes, especially if I know the family well. And I think that makes a very unpleasant experience a little bit more bearable. That's just my take on it.
How'd you get that cheeseburger, Chad?
Delivery app.
It looks like you haven't been following your diet.
Diets don't work.
Have you been taking your insulin?
I don't want to lecture, Nick.
What?
I'm here because my toes killing me.
Severe gangrene.
So a gangrenous, this is really gross. A gangrenous toe could be so infected and dead, it's basically necrotic, that means dead tissue, that it can fall off like that. Obviously it's a little exaggerated. The smell is probably the worst part of all of it because the bacteria, once they eat your tissue, they release a very foul smell. It will light up the entire room. I'm not talking about you have to sniff the wound. As soon as you walk into the room and there's gangrene present, you're gonna smell it. That is very true.
New admission, 21-year-old girl, history of IV drug use, likely endo.
She was trying to steal Dilaudid, now she wants to leave AMA.
She's been spiking fever, vomiting.
She's using again. She took all my money and put it on.
Those who use drugs, especially injection drugs, they're predisposed to a whole host of illnesses. So this is a common presentation, unfortunately, especially in light of the opioid epidemic that's going on right now. When you inject into your body anything, especially in a non-sterile technique, meaning the needle isn't clean, your skin isn't clean, you're more predisposed to things like meningitis, endocarditis. Meningitis is an infection of the pads surrounding the brain. Endocarditis is an infection of the heart valves. These are life-threatening illnesses that can make you act this way because bacteria is festering in your body. And unless it's treated quickly and correctly, you can die. And that's just talking about infection. Think about all the other things that could be going on. When you're under the influence of drugs, it's very possible that you're acting this way as a result of an overdose from simply the drug. When a patient comes into the emergency room and they're presenting with this kind of outcry, screaming, what we call altered mental status, AMS. We have to figure out, is it related to the drugs? Is it because of infection? Is it something more sinister? Has this patient had a seizure? There's a lot of things that are happening simultaneously in the doctor's mind, so it's not an easy situation to deal with, but ER doctors are the front line in dealing with this, and then once the patient is stabilized and ready to be admitted into the hospital, it then goes to internal medicine doctors like this gentleman or family medicine doctors like myself.
If you walk out of here without any antibiotics, this will kill you. If you give us a chance, we can save your life.
I'll stay if you give me 3 milligrams of Dilaudid.
2. If you calm down.
I can't say what he's doing is wrong because she's likely withdrawing from Dilaudid or opioids or heroin, whatever it may be. In order to help her condition, it's possible that you need to taper her off, meaning give her smaller and smaller doses, more spaced apart, of the same chemical that she normally gets high on. Plus, if it's gonna make her reconsider and stay and get treated with antibiotics for her endocarditis, you're saving her life. Some people may disagree with his approach and say absolutely not, she's not getting Dilaudid. Some will say that there is a medical benefit. So that's why practicing medicine is an art. It's not a science, because 2 doctors can look at the same situation and have different approaches for solving it. I understand what he's doing and I sort of respect it.
Baby!
Get a crash cart.
Come on, Chloe, baby.
I'm not getting a pulse. Code blue and ED alpha. Get out of here.
Someone falls and they have no pulse, you call for help, and without even thinking about it, you're pumping on the chest compressions. Chest compressions save lives. I've said it before, chest compressions, I'm gonna say it one more time. Chest compressions is the first thing you do. Even if you have no training in it, start pumping on the chest.
You're running the code.
I've never run a code.
Do you want an amp bicarb?
He's in charge.
Page anesthesia.
When you're running a code blue, you're following the advanced cardiac life support algorithm. It's literally written out for you. You give each person a role, you do chest compressions, you monitor the medications, you monitor the time, you monitor the rhythm, and everybody has roles. After that, there is a specific algorithm. You literally follow steps on little cards that you can carry in your pocket of when to recheck the rhythm, what medications to give, what options of medications do you have, what dosage.
What is the first question you ask in the code?
Rhythm. What's a rhythm? PEA.
PEA is pulseless electrical activity. It basically means the heart has a rhythm, but you do not feel a pulse. There's some electricity going through the heart, but it's useless because it's not creating enough of a muscular motion within the heart to create a pulse to make the heart beat. PEA is not a shockable rhythm, meaning you do not use the paddles for that. You use epinephrine, you use drugs, you use chest compressions, and you hope to get the patient back, and you wait for the rhythm to change into one of the 2 shockable rhythms.
Should we shock?
No, we can't. A rhythm's not shockable. Get me one of Epi. Make those compressions harder and faster. Prepare to intubate.
So when you're doing chest compressions, you want to make sure you're doing quality chest compressions. You want to push at least 2 inches deep into the chest, which sometimes can break ribs. It's a horrible sound to hear, but you're doing this to help resuscitate the patient, basically bring them back to life. So if on the off chance you break a rib, that's okay. It does happen in elderly folks much more than in young folks. You also want to do it to at least 100 beats per minute. So if you think there's 60 seconds in a minute, you're pushing a little bit faster than once per second. A good way to sort of monitor if you're doing it right is to sing the song in your head, please, Staying Alive, because that does go to about 100 beats per minute. It's the classic way that we're taught. Staying alive. Funny that it's called Staying Alive and we're trying to bring someone back to life, but that's some of that raw medical edgy humor.
It's been 24 minutes, it's time to call the code.
No! This is my code. You gave me this code.
Start the cooling protocol for mental status.
We got a pulse.
You saved her life.
Doing a code on a young person for 20 minutes is not unrealistic. Also not unrealistic to recommend stopping the code because the brain without oxygen for 24 minutes is obviously very dangerous, and even if you bring the pulse back, will the brain work again? You won't even know until the person wakes up. The first line that one of the other residents tells them is, "You saved her life." In reality, that could be a great thing, but also on the other hand, it could also be an awful thing because she may just need to be on a ventilator for the rest of her life, functionally brain dead, just her heart beating and her lungs working because she's on a machine. So Very difficult situation to find yourself in.
You came in here all bright-eyed and bushy-tailed, ready to save lives, but today you didn't save a life, you saved a brainstem. Because you didn't listen to me.
Did he do the wrong thing? Not necessarily. In this situation, especially because her family looked like they were there, this is a time to have a conversation with the family very quickly and explain to them what's going on, explain the consequences of, hey, if we bring her back at this point, 20 minutes in, she could come back with a pulse, but also be brain dead, and help them decide what to do in the situation. Allow them to make the decision because, you know, they're her next living kin. Some hospitals have a cooling procedure that when someone undergoes either a heart attack or a sudden stoppage of the heart like she did, that they cool the body down, which slows the metabolic rate, which can help the brain survive a little bit longer. So this doesn't always hold true. Don't use this as an application for your own life or making decisions for your family's life. Treat each situation on its own. Talk to the doctors in front of you and make the best decision that you can with the information given to you at the time.
What was rule 1, Devin?
Do whatever you tell me to do. No questions asked.
All we want to do is help our patients, but what they don't teach us in medical school is there are so many ways to do harm.
The first job of a doctor is not to heal, it's to first do no harm. Because if you look at the history of doctors in the past, we've made a lot of mistakes, over-treating patients, under-treating patients, deciding what's right for our patients and going against their own wishes. I think we've done a lot better in recent years, but there's still plenty of room to go to improve.
If it were easy, everyone would be a doctor because this is the best job in the world despite everything. Because of everything.
An influx of patients so great. At the different hospitals that I worked, there were different definitions of code followed by a different color. For example, code blue generally meant that someone's heart stopped or they weren't breathing. Rapid response meant something. Code pink sometimes meant that a baby was abducted from the newborn nursery. Code black generally referred to like a terrorist threat or some kind of crime going on. I've never heard this type of definition from this show, but it does make sense. Hospitals get overcrowded, especially in busy areas like Los Angeles. I'm excited to watch this.
Your mama knows when you're lying, crying, or dying. And it's not only my job to teach you right from wrong, but to make sure you don't leave here in 3 years thinking you can do no wrong.
One of the biggest things you have to do as a doctor is learn that there's a lot you can do wrong. I'm talking about over-treating, over-diagnosing patients. That's truly a health hazard that most people don't even think about. So I love this nurse, and frankly, I love this actor, so I'm super excited to see him in the show.
The most famous strip of hospital real estate in the nation, where emergency medicine was born, where the Secret Service preserves a trauma bed for the President of the United States when he is in Los Angeles. This is Trauma 1, Angels Memorial. You are not, under any circumstances, allowed to kill a guest in my house.
I love this orientation. This is so good.
What the hell's a homeboy drop-off?
Gangbangers leave the wounded on the sidewalk.
I've worked in numerous hospitals where the ER was in a part of town where there was a lot of gang-related activities, and literally people would walk into the hospital or get thrown out of a car with a gunshot wound. And there was one time I literally got a patient that crawled into the emergency room bleeding from his femoral artery. So I had to grab a glove, stick my finger into his femoral artery, and pull him to the bed and get the whole process started with the trauma team. I remember that because my hands were so covered in blood, at least up to my elbows, that I was like, oh man, I have to wash this off really quickly because that's the first step of infection control is to wash your hands. I left the trauma scene in the trauma bay and walked to one of the nearest sinks to wash my hands properly because the situation was being taken care of by a lot of doctors. And then I realized I was tracking blood all across the hospital. So The maintenance staff looked at me with these angry eyes and I was like, I'm so sorry, I didn't mean to make a mess. But literally they had to clean up my bloody footsteps that traveled halfway across the hospital to go wash my hands. It's part of life. It's scary, but it's part of life.
Gunshot wound to the neck, obliterated carotid. He's lost half his volume here, Jesse. We gotta get him out of here.
Let's get the gurney underneath him, please.
All right, you get over there on the other side and push with both legs. 1, 2, 3, go!
So this is very realistic. I know it looks like they're being rough and they're kicking the patient out of the SUV, but that's true because you literally have seconds before the person completely bleeds out and dies, especially from the carotid artery. Plugging the wound obviously is the first step, so they're doing a great job. I'm assuming they still feel a pulse because they said that the artery was still wiggling. So right now, the most important thing is to fluid resuscitate this person, meaning to give as much fluids as you can with 2 large bore IVs. Large bore meaning thick IVs so they can deliver a lot of fluids very quickly. And then it's to obviously give them blood back, donated blood that we have in the hospital from the blood bank, and give them as much blood as we can in a short period of time.
Look at his pulse, doctor. This man's heart needs assistance. Stop compressing until you can intubate. You got it?
Yeah.
Who can tell me why this patient cannot be transfused with type and cross-matched blood? Anyone?
Because it takes time to type and cross someone's blood, so therefore you want to give them blood that's universally considered donor blood, which is O negative blood.
I need a hero. Come on. Come on, let's go find you an attending to annoy.
Honestly, this is so accurate because at times the hospital's busy. You have to find a doctor to shadow or learn from or follow around. And it is sometimes unorganized like this, especially when it gets busy.
What's your name? Ariel. Ariel. I'm Dr. Warish, and the truth is we don't know why your father's unconscious and I can't learn anything out here in the dark. So with your permission, I want to take him inside. And I promise you, I will tell you everything I know as soon as I know it. Okay?
Very good doctor-patient relationship. I found myself very often in the emergency room having very serious conversations like that, and I found like that yields the best results. So even in dire situations when a family is hysterical like that, the more honest I was with them, and I was brutally honest at times, saying that these treatments aren't gonna help your father, mother, whoever I was talking about at the time, and I would apologize. I would say, I'm sorry I'm being brutally honest right now, but I want you to make the best decision with the limited amount of time we have. And people respected that, they appreciated that, because in reality, nobody wants them to lie to them. Nobody wants false promises.
What's your evaluation, doctor?
Patient unconscious, low BP, warm extremities, he's in spinal shock.
No additional examination.
It's pretty textbook.
Pretty textbook, huh?
Yeah.
Okay, what about you, Dr. Textbook?
The way that this attending is teaching while trying to actively save the patient's life is very accurate. Like, I feel like I'm in the hospital as a resident learning. It's very accurate. This is exactly how it happens. She's not giving the patient worse care, but she's also educating with pressure in a time-sensitive situation to the residents. Excellent, excellent recreation.
654 is normal brain function, 111 is the lowest. He's brain dead. That poor kid.
He was confused that I didn't understand him.
Yes. Called expressive aphasia. It's word salad. Sounds right to him, but the words come out all tossed around.
Yeah, expressive aphasia is really interesting. It's also known as Broca's aphasia, and that happens if you have damage to the left frontal area of your brain. So that can happen in car accidents, it can happen in traumatic illnesses, also strokes. Basically what happens is, in your mind, you know what you want to say, and you think you're saying the right words, but when it comes out, you're saying completely different words. And the way that I memorized this when I was studying and learning about it was boca means mouth in Spanish, so it was like what's coming out of your mouth is wrong.
TPA is a kind of miracle drug that has the potential to bust the clot up and reverse the stroke, but only if there's no actual bleeding yet in the brain. We're gonna need a scan to know for sure.
So this is the one part about this that's pretty inaccurate. So most hospitals have stroke protocols. When a patient even comes in with remotely similar symptoms to a stroke, they instantly go to a CAT scan. They instantly get blood work drawn. You instantly page the internal medicine or family medicine residents to follow a stroke protocol. We instantly call the neurologist and get the robot out. And all of this happens right away because, again, you have a small time of window that you could actually give the TPA. So it's about the fastest way you can get things done. Never is it standing at bedside having conversations of, oh, let's get the CT scan and see if there's any bleeding going on. No.
He's brain dead.
Oh, God. And she's all alone until tomorrow.
Has someone called Child and Family Services to come get her?
Yeah, but you know how that goes. It could be ours.
It gets worse. He's an organ donor. Transplant team's on the way.
And we can't wait for CFS, I have to tell her.
This is definitely the most medically accurate show I've seen in such a long time. I don't know why I'm getting excited about it, but it's very accurate. These conversations happen in this matter.
The father died, Ariel.
Well, technically, it's a brain death.
So he's not dead?
No, that's... What I mean is, machines are keeping his body in a state of...
What are you saying?
I'm trying to explain to you.
No, you're not. What happened? Just giving it to me straight.
I'm giving it to you straight.
So he's dead, but technically not really, right? No, I want to go see him. I want to see him.
I've had conversations like this. Again, the more brutally honest you can be, at least in the beginning, that's usually the best policy. My general strategy is to get as much of the information out there, console them as much as I can, but if they become hysterical, get upset, tell you to shut up, tell you to leave, never get offended, because what they say in those moments, that's not who they are as people. They're going through a moment of shock, emotional shock. I'll leave them alone in the room with maybe someone watching them, a nurse or someone else, but me, because I'm the one who gave the bad news. Give them some time, and then come see them when some time has gone by. And pretty much every time that I've done this conversation, they apologize, we hug. I understand that they've just lost a family member. I've gone through that in my life with my mom. I've actually had to ask residents to stop doing CPR on my mom, so I know what this feels like. And sometimes people just need a moment to themselves. They need to not see the person who just gave them the bad news. So it's okay to be the bad person. Leave, come back.
Transplant team's en route. I want to tell you how fabulous you look right now.
I do?
No, I wouldn't tell you that, but then it'd be a lie. You look like you've been strapped to the bow of a ship.
So true. This is so true. Interesting about the transplant team, they are a skilled set of surgeons that come in and basically take the organs as soon as the time of death is called. Actually, when I was doing my training, when I was on the surgical unit, I was one of the people that was put in a room with the transplant team to call the time of death. You cannot start to operate on the patient, taking out the organs, harvesting the organs, what have you, until the person is completely dead. So we had to stand there until I didn't feel a pulse and my exam was negative. There was a lot of pressure, and there was a time where there wasn't a pulse, and then it came back, so I had to say, well, wait. And it was a lot of pressure on me being a young doctor, but I wanted to do what was right by the patient and waited until the heart completely stopped. The patient had no pain response, and only then did we begin taking out the organs so they could save someone else's life.
No, don't do that. You don't need any more laugh lines, believe me.
Me? Have you looked at yourself in the mirror lately?
I love their relationship.
I love you so much, I want to break you in half.
I love you so much, I want to punch your face in.
There was a recent article whether or not it's okay for doctors to hug patients and other coworkers. And I thought it was insane, because if we're gonna get to the state of where we're not allowed to make physical contact with people, humans crave physical contact. I'm not talking about inappropriate physical contact. I'm talking about moments like that where you need encouragement, where you need a hug. Even most recently, I had like an 84-year-old patient that was going through a difficult moment in her life, and I spent an hour with her on a visit. We talked about all the things going on. We treated her medical conditions. She became very emotional and cried and asked for a hug. Of course I'm gonna hug her.
The worst part is the headache. I live above the boiler room in my building. The noise just keeps cracking my head open. Is there anything you can give me for that?
You're 9 months pregnant. There's not a whole lot we can do other than give you Tylenol.
I've tried that. It doesn't work.
You using again?
Excuse me?
Mario.
Scars on the inside of your arm, no track marks, right?
None of your damn business.
Bad bedside manner, obviously. I've never seen a more aggressive resident in questioning a patient. You're gonna get the patient angry, whether or not you're right or wrong. It could bring up old feelings or old habits that the patient had that can make them very emotional. They're gonna disconnect, they're not gonna follow what you're saying. No one's winning here by you doing that. Shame on you, sir.
Where are you from?
Norway?
Center Station. Your son has a collapsed lung. We're gonna help him.
How could you know that?
If a Norwegian kid can't breathe, it's a pneumothorax. It's a genetic predisposition.
I've never heard of that. I'm about to have spontaneous pneumothorax. A Norwegian child having a pneumothorax? I'm learning something from this show. I'm gonna look this up afterwards. Actually, let's look it up right now together. I'm curious what pops up here. A significant fraction of families with familial spontaneous pneumothorax have mutations in the gene. The fact that she's just guessing that this child has a pneumothorax without a physical exam is a little crazy for me.
Diesel fumes, oh my God.
What?
What if it's
She lives on
carbon
top of a
monoxide?
boiler room.
Carbon monoxide poisoning can mimic flu symptoms. She said she lived above a boiler room, right? Oh my God, Mario, I could kiss you. But not really.
Common symptoms of carbon monoxide poisoning is feeling sleepy, having a headache, fatigue, and the treatment is breathing in oxygen.
You're not gonna like this, Neil.
She has to perform a C-section on the rig. Sometimes you gotta be a cowboy, right?
Oh, God. Oh, okay. Now, it's gonna happen very quickly. I want you to reach your hand inside as fast as you can. Carefully, feel for the baby. When? Have you made the cut yet? Yes. Now. Yeah.
These are very crude instructions, but I guess in an emergent setting, this is what they need to do. It feels like they're making a rash decision here in doing a C-section like this with someone who's not a trained operator. There's so many mistakes that can happen. I don't know. I don't know what the right answer here is.
I got her.
How about suturing the patient back up so she doesn't bleed to death?
Hi, I'm Vanessa. I'm Ariel.
Oh, the organs were used to save her.
Can you hear it? Yeah. I can hear it.
Powerful moment when you know you had to lose your father, but it saved another person's life.
As first-year TVs, you guys will be on pediatrics. You'll help with clerical work, transpo, keeping patients company.
Yes. Babysitting. Great.
That's right, Georgia.
This feels like the exact same intro that I think Grey's Anatomy started when we did our first Grey's Anatomy review. It feels like a little hazing is happening here. And we don't haze our volunteers in the hospital.
Ambulance Bay needs hands. Patient Dr. Henry and everyone on call. Metro bus crashed downtown. We're about to be at capacity.
Somewhat similar does happen in the hospital. We have a triage nurse. For example, if I have a patient in my outpatient center that I need to be seen in the ER, I call ahead, the nurse triages it, gets the doctor ready. If we need a trauma bay, they get that ready, all the equipment. You want to be prepared.
This is Maeve. She's our top second year. She's gonna finish the tour while I go home. I'll be back when I can.
I also didn't know that volunteers have years of seniority. Like residents have that, like first year, second year, third year, fourth year, and they have seniority over each other. I feel like this show is grooming teens to become hardcore fans of Grey's Anatomy. What were those chest compressions? What is this? You gotta use the full weight of your body.
This is gonna suck.
This is gonna be amazing.
I'm not gonna lie, the person who's there on the first day of introductions and they're taking notes, I was always super intimidated by that person. Should I be taking notes? Am I missing something? What if they're gonna know something I don't? And then I realized sometimes you need to take notes and sometimes you just need to be there, present as a human.
There's a lunch tray in here for everyone. Make sure everyone eats at least half before you leave.
What happened to a proper orientation? Teaching them how to use safety equipment, knowing when to notify senior staff, putting on gloves and gowns. These things need to be taught. And I hope they were checked for their immunizations because the last thing we want is our volunteers spreading illness throughout the hospital.
Why did you volunteer to work in a hospital?
I got arrested. Beats juvie.
Do not blow into a glove with your mouth before you put it in. A, it's not really hygienic because you have a lot of bacteria in your mouth. But number two, there's humidity that comes from your mouth. And have you ever tried to put your hand into a wet, moist glove? And it's hard. Fun fact, those beds are accurate, they're legit, and they're insanely expensive. ICU beds are $25,000 to $30,000 each. I've seen those go even higher. And medical beds, which are just the plain ones, are $5,000 to $10,000 a bed. Imagine a 300-bed hospital. It's a lot of moolah.
I'm a little worried right now because I'm losing a lot of blood. And my favorite sweatshirt.
You should be fine to wait a little. If you hit an artery, you would have passed out by now.
Oh, we have pre-med students up in here. She's like, if you hit an artery, you wouldn't be here right now. Yes, but why in the world is she making contact with a patient and giving medical advice? Huge no-no to our volunteers. Can you be there? Can you help them out? Can you do all these things? Yes, but you're not trained to give medical care, no matter how many of my YouTube videos you've watched.
6-year-old female, 3rd-degree burns, possible smoke inhalation. We couldn't get a line in.
Give me a 24-needle norepinephrine. What else can I do?
Oh, you've done more than enough. You can go back to your normal duties.
Okay.
She's close to coding.
Come on.
Show me a vein.
None of this is medically accurate. She's close to coding? What? If a patient's not breathing, that means they're coding. That means they're dead and you need to bring them back to life. And that means you need to do chest compressions, chest compressions, chest compressions. And this doctor asking for a 24 gauge needle, I don't even understand what he's hoping to do here. If he's trying to start an IV, you don't start an IV with a 24 gauge needle. You start with an 18 gauge needle, which is much wider. None of this makes sense. I love that the doctor, while he's reaching for the syringe, he's reaching for it and he's still tapping on her elbow. Like, what are you doing, my man? What are you tapping for there? What are you trying to find?
What did you do to get arrested?
In prison, you're never supposed to ask about the crime. Come on, dude. You're the last one. You have to eat. Hey, don't ignore me.
Hey, Jack, maybe try a gentler approach.
Oh my God, this is so awkward. It's cringy. Hey, why don't you try a gentler approach?
Stevie, sweetie, you need to eat to get big and strong and feel better. No. It's actually really good. Let me show you.
Did she really take a bite off the spoon and then she is giving the same spoon to the child? Oh. I love that my man is just standing there in a shearling jacket. Maybe take it off. Make yourself like you're at work. Put on a uniform, not a fancy jacket like you're part of an after-school play for the Lost Boys.
What are you doing?
Oh.
Don't come any closer.
I don't think that's gonna hurt anyone.
Depends where I put it.
The cardiac rhythm behind them is like the scariest rhythm ever. And there's 10 of them, go figure why, in different colors. They were like, let's just put them all on the screen because they're colorful.
Squeeze as tight as you can. Now don't worry about hurting her. Good.
What is-
A minute longer. And we're in.
What is he doing? This is just insanity.
Keep up the rescue breaths.
Nothing changed on the screen. What is happening? This could be the worst medical show in the history of medical shows. Doc McStuffins was more accurate.
Busboy, why are you back here?
Just waiting to get my stitches removed.
Mind if I take a look?
Two problems here. One, why in the world do you go to the emergency room to get your stitches removed? You could go to your primary care doctor's office and save a huge ER bill and a wait in the ER. Two, why is the volunteer taking a look at anything medical? That is not ethical, it's wrong.
Sutures look like they healed nicely. Shouldn't have too much of a scar.
This is like what people must think happens in hospitals. Like the writer was, I wonder what volunteers do. They must help with patients. No, they don't. Can you imagine someone with zero medical experience giving out medical advice? Oh wait, that's like Gwyneth Paltrow and Goop. I guess it does happen.
Nurse Sandy told me to be careful. One of the boys bullied the other, and it's pretty dangerous.
Ugh, bullies are scary.
I've never seen a medical uniform specify the age of the person wearing it. It doesn't say medical volunteer, it says teen volunteer. Who needs to know that information?
Where are you headed?
I was on my way to the supply room. For supplies.
That's funny. So was I.
I didn't know you were Dr. Henry's protege.
I didn't know that volunteers were considered proteges. I used to think that would be a role for residents or med students, nurses.
Smart is the new sexy. I read that somewhere.
Cringe, cringe. I appreciate it though. I like people representing smart folks. The fact that he said he read it somewhere means he reads.
I'm so sorry you're hurting. How about an ice pack for that eye?
No, I'm good.
Can I get you some pudding? Juice?
You know what's really important? Whenever a patient is admitted into a hospital or coming into the emergency room, there are certain orders that we place as doctors, whether or not a patient is allowed to eat and what kind of diet they have to follow. Because some patients have trouble swallowing certain foods. Some patients should be NPO, which means nothing by mouth, because they're going for a procedure or perhaps a surgery. So the fact that these kids are running around the hospital and offering people food, while is nice in theory, that's not their job. And they need to be really careful who they're feeding, because if someone is going for a surgery in an hour and they give them a sandwich, that's a problem because the surgery is gonna get canceled.
You know, I've never been in a fight. Maybe you can give me some pointers.
I'm not sure this device that he has on his head, I've never seen it before. I honestly don't think it's a medical device, but because I haven't seen it and because I'm not technically a trauma surgeon, I'm not gonna comment on it. Looks shady though.
You really don't know where the bandages are?
Oh, I do. I just needed an excuse to get you in here.
You don't even.
If you hadn't snitched, I'd still be on the lacrosse team. I should have hit you harder.
Hey, enough! What is it with you kids? You can't follow the simplest instructions.
I love that all the medical dramas are all doctors doing everything. Transporting patients, ordering tests, performing the surgeries, talking to the patients, everything is them. And in this show, the volunteers are the only ones. They're treating the patients, they're breaking up the fights, they're making out in the hallways. What is going on? Include other characters. Healthcare is a collaboration.
You're supposed to protect your patient, kid.
What are they, police officers? You're supposed to protect and serve as a volunteer.
Can you tell me what happened to Holden? No updates, kid. Holden has a severe heart condition.
We don't give patient information out to volunteers just because they have crushes on them. Patient information is a protected entity. Oh my God, for a chocolate bar?
Is he gonna be okay? It's not a good prognosis, but he's at Attaway General getting the best care there is.
I may have to disagree with you on that little point. In fact, probably more like Attaway Funeral Home as opposed to Attaway General Hospital. Just saying.